with a solo presentation, which is of Dr. Sutapa Neogi. She is the director of IIHMR New Delhi, and she'll give a speech on the impact of PM Ayushman Bharat on sustainability of empaneled private hospitals across 2, 3, and 4-tier geographies. Can we have a big round of applause for her?
So, a very good afternoon to all of you, and welcome to the first post-prandial session, which are generally the most difficult session because after lunch, you know what happens. So, I'll try to keep it short and simple, and I would expect that if you have any questions in between, you are free to stop me and ask any question at any point of time. So, as you would see that the topic of this presentation is impact of PMJY Ayushman Bharat on the sustainability of empaneled private hospitals across 2, 3, and 4-tier geographies. It's not a very simple topic, but I'm very happy for the fact that sessions like these have been arranged in a symposium or conference where there are several industry partners. And you would appreciate that if you don't have a very strong and a very lively public health system, industry will never be able to grow. If you're still grappling with the usual crisis, obviously healthcare industry will never be able to progress the way it should progress. So here I am to tell you something about this PMJY Ayushman Bharat. I'm sure you are familiar with different components, but as a ritual, I'll just take you through different components and we'll see how we are performing at this point of time. I hope you all are familiar with the healthcare system of this country, where it is divided into primary, secondary, and tertiary. So this is the pyramid that we keep talking about and referring to all the time. Unfortunately, currently the primary healthcare covers only 15% of the health issues. I don't know what is happening to them. It covers only 15% of the health issues, and whatever gets covered at the primary level are mostly related to maternal and child health. But as we are going through the epidemiological transition, we know that non-communicable diseases actually form a bulk of the burden of mortality and morbidity, where only primary healthcare may not be the appropriate mode of management. In India, on an average, as reported, we have 9 beds per 10,000 population against a global average of 30, and half of these are in the private sector. So we have pledged through our national health policy that the health expenditure as a percentage of GDP would increase from 1.15 to 2.5. And to make this happen, there are 2 flagship programs which have been introduced in the country. One is to create the health and wellness centers to provide comprehensive primary healthcare services. This is nothing new, but this is only an upgradation of the existing sub-centers and the primary health centers to health and wellness centers to provide the PHC services in a very comprehensive manner. The second and the most important thing is about the Pradhan Mantri Jan Arogya Yojana, which we call PMJY in short. And we are very proud to have this feeling that PMJY is probably the world's largest healthcare program currently. So obviously all credit goes to the current government who had made it happen. So now if you look at the key components of PMJY, the first is the target population, where we say that we have to target more than 10 crore population, and particularly those who are poor and vulnerable, and there is no limit on the family size or age, which is an improvement or deviation from the insurance schemes which we were having earlier. And as on 9th October 22, we already have more than 3 crore hospital admissions recorded as available from the portal. We have been able to make it more institutionalized in the sense that we have a national health agency or authority at the center, and then every state has a state health agency, and they are free to adapt and adopt and reform the guidelines as and when it comes from the NHA. Financing, the funds are shared between the central and the state governments. In terms of the benefit package, there's a cover of 5 lakh INR per family. Medical surgical conditions are included with minimal exclusions, and we also have pre and post hospitalization expenses covered. And this can be implemented through trust or insurance company. Now there was a report which was published around a year ago where they were trying to see what is the preferred mode of insurance, and it was found that the health facilities in the public sector, they were generally preferring the trust mode, whereas those in the private sector, they were going for the insurance mode, and particularly this was true for those private hospitals which were not for profit institutions. Now, how do we validate the beneficiaries? For this, identification is compulsory in the form of an Aadhaar card. In case this is absent, then any other national ID card would serve the purpose. And there lies the problem, because if you're talking of tier 2, 3 and 4 cities, there are many places where people do not even have an ID card in that sense. I mean, it was the situation around 2 years ago. I think things have become much, much better currently. So here was a study where they were trying to see what proportion of beneficiaries by the source of eligibility checking. So it was just a comparison between two states like Madhya Pradesh and Gujarat. Interesting enough, in Gujarat they found that around 82% of the beneficiaries, they had already received a notification or intimation from the government of Gujarat that they are eligible for the PMJY package. This is the level of awareness that we want in every state. But this was not true in Madhya Pradesh. And the reason they say is that in Gujarat, because of the previous experience, people were already sensitized to this fact. So what it means is that we need to create a level of awareness among the general public so that they are better prepared when they attend to any hospitalization, attend to any health facility for hospitalization. Otherwise, obviously, time goes by and people may not be able to avail the right facilities which they are entitled for. But on the other hand, in both the states, it was found that the level of satisfaction who had availed these services through the PMJY scheme, they were very good. So that is a positive sign. Now, who could be the healthcare providers? All public hospitals, private hospitals based on defined criteria, and there are defined procedures which were supposed to be reserved for the public hospitals. As on 25th November 22, we have more than 15,000 public hospitals empaneled, more than 13,000 private hospitals empaneled, and overall it is close to around 30,000, 28,000. But what is important to note is that most of the hospitals which are empaneled, they have a bed strength of 0 to 50 beds. Although there are criteria for different bed strengths, but majority of the hospitals, be it private or the public sector, who are empaneled, they have a bed strength of 0 to 50. Also, when we tried to see the number of hospitals empaneled state-wise, we found that the maximum number of hospitals were empaneled in states such as Tamil Nadu, Karnataka, UP, Gujarat, etc. But the same when we were trying to tally with the authorized hospital admission, it was not actually concurrent. Which means that only in Tamil Nadu we had the highest number of hospitals empaneled and maximum number of authorized hospital admissions. So this is a kind of a discordant figure which we found. And the reasons could be many which we obviously couldn't explore. But interesting enough, in 9 states, there are more number of private hospitals empaneled than the public hospitals. The states which are colored in red, example Rajasthan, Haryana, Maharashtra, Karnataka, Kerala, all these states have more number of private hospitals empaneled as compared to the number of public hospitals. Now, what could be the problems? These are again the problems which are documented in different documents in the literature. It is said that most of the empaneled private hospitals are in the urban areas, which is very unnatural thing. And most of the empaneled private hospitals are from the richer states. So in the poorer states, people still rely more on the public health system probably, and that is the reason why the empaneled or the number of empaneled hospitals in the private sector is less in the poorer states. Also, there are poor availability of hospitals in geographically challenged areas. This is also a normal thing which can happen. But the approach to empanelment of private provider is governed by the public health infrastructure. So in places where there is a very strong public health infrastructure, the empanelment of private doctors or private clinics was less. Again, for tertiary care services, we have the 50 beds are minimum. It is a requirement. But we have seen that even those with only 10 beds, they are empaneled as a tertiary care center. But since states are allowed to amend their own way, so one observation which came from Bihar was that they said that we would empanel only NABH accredited private hospital. That also puts a kind of a restriction on the number of empanelments in the private sector. But as per the data which was published in 2020, only 3% of the private hospitals are eligible for empanelment. And this is a very scary thing, although we are talking about public-private partnership and expansion of the private healthcare services, but going by the rules and norms, it was stated and documented very clearly that only 3% as in 2020. So now in 2 years, things may have improved a little, but I don't know how much improvement has happened till now. And the bulk of the hospitals which are empaneled by insurance company had a bed strength of less than 50. And this is what it is. Now, another important norm under this PFJOI scheme is that the hospitals are to be on a fixed package rate based payment. And this would be fixed by the government in advance, and no additional money is supposed to be charged. Now, again, as documented in one of the studies, it was found that for a single specialty hospital, there are more private players than public. But as we increase the number of specialties, the number of private clinics empaneled increase. But for when the number of specialties was more than 20, the public sector empanelment was much more. Which means that not every private clinic would be there to provide all the services in one go. So this can be thought of as a limitation, or this could be a strength also, depending on the expertise available. And the specialist services which are generally available in all the empaneled hospitals were related to general medicine, emergency room, general surgery, gynae obs, orthopedics, etc. Now, when we disaggregated this by public and private, again we found that more specialized services were being offered by the publicly empaneled or the empaneled hospital from the public sector, not the private sector. So this again poses a kind of a limitation, but obviously in 2, 3 or 4 tier cities, you do not expect a private hospital to provide all the super specialized services in that sense. So the critical observations that emerge from all these findings are, first of all, we don't have any reliable data on private sector infrastructure. That is a very big limitation on the part of the private sector, which is where we are not even able to compare and see where we stand. Moreover, when the private sector were allowed to report the kind of services that they would provide, they generally reported a narrow and selective range of packages. It was not very comprehensive. Also, some of the states had made some amendments in the sense, suppose in Maharashtra they said that they would empanel limited hospital only based on their requirement. Although the number of empaneled private sector was more, private hospitals were more, but they said that we would empanel only based on our requirements. In states such as Bihar and Madhya Pradesh, they had reserved some packages for the public hospital exclusively. So then that also becomes a restriction on the part of the private sector. In Uttarakhand, for example, they said the referral from a public hospital is mandatory for every procedure that is carried out in the private hospital. So it means that every person would first have to go to the public sector, get a referral, and then only the person would be entertained in the private sector. It is a kind of a harassment for both public, people and the doctors, but this is what it is. Some abuse-prone packages, for example, hysterectomy, are reserved exclusively for the public hospital. So this was maybe done intentionally, but this is what it is. Surprisingly, it is reported that nephrology not included in the packages Although dialysis is a very sought after procedure among many other essential services. So this again is a limitation. And 71% of the hospitals empaneled have less than 25 beds and they offer non-specialized services. And also it was reported that this scheme, PMJY scheme, will provide the coverage of medicines only up to 15 days post-discharge. So these are the critical observations which have emerged from the data, and now a lot of discussions and deliberations are going on to see how we can join hands and improve the scenario on the whole. Regarding hospitalization services, the beneficiaries will get treatment only on the basis of the verification, which will happen through an IT portal. But as reported, PMJI covers less than 30% of the hospital charges. This is only as reported in the literature after interviewing the beneficiaries in select states. So that report particularly very emphatically spells out that PMJI has neither resulted in a reduction of out-of-pocket expenditure nor incidences of catastrophic health expenditure. But the magnitude of the out-of-pocket expenditure was much, much higher in the private sector, which is again a very natural thing to happen, but this is what it is reported. And because this PMJI payment will only happen after hospitalization, there was a trend that patients are asked to pay for the pre-operative diagnostic procedures due to a concern that they will not receive the payment if the patient is not hospitalized. So maybe unnecessary investigation and diagnostic tests, and then taking those money from the patients actually increase the out-of-pocket expenditure. And the same findings have been reported from other countries as well, wherever they have tried to institute this kind of an insurance system within the health system. Now, strengthening of public health facilities is also one of the agenda behind this PMJY scheme, and they say that public healthcare facilities will retain the claim amount, and this would be used to improve their own infrastructure in the public health setup. Now, what is surprising is that 40% of the public health empaneled hospitals, they were the PHCs. So I don't think any primary health center would be in a position to provide all those services, secondary and tertiary level services. So why this has happened, that also nobody knows, but probably the thing was that initially they just wanted to empanel many hospitals from the public sector, and there was some relaxation in that regard. But the same was not applicable to the private sector hospital. So there is a kind of a discrepancy, a discordancy in the data that more public facilities were there, but they were at the primary healthcare level, health center level, which was not actually expected. Now, prevention of fraud and misuse, it mentions that pre-authorization will be made mandatory for all the tertiary care packages and select secondary care packages, and there will be medical or claim audit, data analysis, and standard treatment guidelines will be used to verify this, and for this appropriate softwares are in place everywhere. But within 1 year of launch of PMJY, 1,200 cases of corruption were reported. Investigations were conducted in 376 hospitals, and 76 hospitals were delisted from that category. So what it means is that the system is now very strict, and penalties are levied on wrongful claims, weak capacities to comply with the processes, and high claim rejection rates reported from some states. These are again the hurdles which have actually come in the way in order to streamline the system. And this happens through the information technology, which is very robust, modular, and scalable. So once the eligibility criteria is ascertained, then Ayushman Mitra, who is there in every PMJY facility, they would block the benefit package using that IT platform. But there is a process which is involved, which means that from the time of admission to pre-authorization, it takes some time. It's a waiting time for the patients. So it was seen that this waiting time was much more, longer in cases of private empanelment or in case of private facilities. Similarly, the time for the pre-authorization approval from the private health facilities was much higher. So this actually also, it affects the psychological status of the patient when they are waiting for their admissions to happen. And this particularly happens in the private sector as reported. And the reasons where the numerous queries are raised because of their incorrect documentation and the weak capacities of the health facilities to comply with the processes. So all those private sectors, they need to be told about the processes, and they should have somebody in place who can manage all these complaints and queries, etc. So a simple thing to avoid all these confusions is that adopt the standard treatment guidelines, which is a very difficult proposition, I think, as far as the private sector, a private hospital in the tier 3 and 4 cities are concerned. This is a ABHA portal which has been created to bring everything together in one platform. And the way forward is that there is a huge opportunity to strengthen the private hospital in tier 2, 3, 4 cities. We have to be clear on what we want. Do we want the private sector only to fill in the gaps, or do we want to be a partner in the whole process? So a lot of discussions are now going around to see how well the private sector can be placed appropriately. And the biggest barrier which gets reported time and again is the mistrust. And this can be averted only if we have our processes in place. So there is a need for professional negotiation and more discussions to foster better collaborations. There also has been a recommendation to say that there has to be a collaboration charter to set out the activities for government and non-government sector. This may sound very theoretical, but at least there has been some movement in this regard so that people are more clear about what they want. We have to follow the standard treatment guidelines irrespective of where we are, irrespective of the geographical location and type of facility. And now there has been another talk which is going on, which is to devise a national pricing index, particularly for the private sector, which will take into consideration the geographical location, number of beds, accreditation status, etc. So it means that the same amount cannot be made applicable to all the packages across all the states, across all the geographies. So again, these are in the initial stages of discussion. Also, there has been a recommendation that if you want to involve the private sector more constructively, why can't we include them in developing the health and wellness centers? That will also give them some space to develop in their own areas and maybe better behave as good partners. And also there's a recommendation that involve the private sector to upskill the government functionaries on fee-for-service model. It means that the people who are working in the private sector, they can impart training to people who are there at the PHC level or above, and this can be, they can also charge from the government for imparting such trainings. And also the duration for which these charges are made applicable should be increased, at least 30 days prior to hospitalization and post-hospitalization 60 days after the service, after discharge from the hospital. So these are again the recommendations which have been put forward. We do not know how many recommendations will actually be taken up or approved by the government and implemented. And as we have been saying that everything is theoretical, everything is there in pen and paper, but this is, I think, it is one program which is trying to make a big change in the whole system. So thank you so much, and if you have any